So we're presenting the poster tomorrow, which represents the results of the VIALE-A and also Phase Ib study of HMA Venetoclax, looking specifically at the monocytic AML. Because there has been a lot of confusion whether these people respond better, worse, or generally worse than the non-monocytic AML. And the thinking is that monocytic leukemias have high levels of MCL1 and low levels of BCL2, and therefore they do not respond as well. So the actual data from this trial suggests that using either FAB classification or gene expression profiling, separating monocytic from non-monocytic leukemias, that the response rate and survival are similar. So there's really no disadvantage of using HMA Venetoclax for monocytic leukemias. But what we found is that the genetics of this leukemia really what makes a difference, because monocytic leukemias could be MPN1, FLT3 mutated, IDH1/2 mutated, or RAS mutated. So the data seem to suggest, again, there's a small data set, that patients who have RAS mutations and monocytic leukemias, their response rates are lower, only about 33% CR/CRi rates, and also overall survival tends to be lower. Now, looking at gene expression, we found that in general, monocytic leukemias have lower BCL2, as has been reported before, higher MCL1 and higher BCL2A1. So these are all factors that are supposed to make them less sensitive to venetoclax. However, the RAS mutated leukemias also had high levels of BCL-XL. Whether that's the reason that they're not doing well, or maybe there's something else that we haven't looked at, we're not quite sure. But the conclusion from the studies are that just looking at the FAB monocytic versus non-monocytic is probably not going to determine how people will respond to HMA Venetoclax, and you should not shy from this therapy if you just have FAB-defined M4, M5. But really looking at genetics, it's what probably drives the outcomes. In particular, I think RAS mutated monocytic leukemias that don't do as well.